Good morning. I'm Jim Harrop, the Scientific Program Chair of the CNS, and I'd like to introduce everyone to our annual meeting, which is a 66th annual meeting in the lovely city of San Diego. With me is Steve Kalkanis, our annual meeting chairman, and Brad Elder. Our first talk is Paving the Way for a New Era in Traumatic Brain Injury by Jeff Manley. Dr. Manley.
Well, thanks everyone for getting up and showing up so early. I think it's really a great and a very exciting time in traumatic brain injury, and I want to talk to you a little bit about some of the efforts that are moving forward. So traumatic brain injury is no longer a silent epidemic. Many of us have discussed this and talked about the fact that this is a huge public health issue, but the public really hasn't been aware. But today they are aware. As we know, we're in the beginning of the football season, and with all of the news and information that's been out there, we still don't even have very good statistics about this, but the CDC estimates that there's between 1.6 and 3.8 million sports-related injuries that are occurring every year. And we used to just think about these as a ding or somebody getting their bell rung. And now we understand that at least in a subset of these patients, that they go on to have lifelong disability from this. And this is a very controversial area, but an area which we need to understand. Certainly, the wars in Iraq and Afghanistan have focused us on really the importance of not just traumatic brain injury, but mild traumatic brain injury. The sort of things that killed our men and women in the service no longer are because of the Kevlar body armor and so on. And today, we're left with over 300,000 servicemen and women who have ongoing issues with traumatic brain injury, and much of this is mild. We also see that despite all of the efforts with airbags and different ways to try to mitigate the effects of trauma, that we have at least 2.5 million people a year that are seeking medical attention for their traumatic brain injury. And over the last 10 years, what we've seen is that as the cancer doctors and the heart doctors have done a much better job in treating cancer and cardiovascular disease, we have this rapidly growing population of elderly TBI that some have termed the silver tsunami. And if one looks at the predictions for the number of elderly folks that are suffering from traumatic brain injury, the curve, the line is really almost a 45-degree line, and suggesting that this is something that's not going to go away. As people get older, they continue to fall. Traumatic brain injury is going to play a larger and larger role in the management of these patients. And unfortunately, because of the way that we've structured our clinical trials, they've typically been excluded, and we know we have issues with anticoagulants and things of this nature. And so this is really a black box, but something that's growing rapidly. So what I'd like to say is that traumatic brain injury is actually one of the greatest and most rapidly growing problems in neurological surgery today. This is not a problem that's contracting. This is actually a problem that's expanding. And what I hope to have you take away from this morning is that neurosurgery really needs to play a prominent role in this. I understand when people train that oftentimes these cases are left to the junior residents. This is typically something that people aren't actually out looking for jobs in neurotrauma. But despite this, this is a big area, and I'm pretty sure that almost everybody in this room still does a little bit of neurotrauma. Why? Because it's, besides back pain, it's the most common thing that we see in our field. It's also a portal to understanding the brain and brain disease. Really from the beginnings of ancient Egyptian medicine, we began to understand about localization and what parts of the brain did this. They understood that the left side of the brain was involved in speech, things like Phineas gauge. We've actually learned a lot about how the brain works simply by looking at the injured brain. I think we also have an incredible research opportunity in understanding plasticity and repair. We've all seen those patients that 2 weeks post-op had hemiparesis, had speech problems, and if we follow them for 2 to 3 years, they actually rebuild their brains. And this is an incredible model for some of the work that people are studying, and actually other models which I don't think are nearly as effective as traumatic brain injury. We've also begun to see this incredible overlap between an injured brain and psychological health, where it's in, for example, 15 to 20% of the folks that we're seeing here in the community that have had a mild traumatic brain injury. If you look at them at 6 months, they go on to screen positive for post-traumatic stress. Twice the rate of depression that's normally seen in the community. We have many, many psychological health issues that are associated with this. And the question is this unmasking them or is this actually precipitating them? So this may give us a window into understanding some of these more difficult problems that we've been faced with, for example, with these mental health issues. There's a big environmental risk factor for Alzheimer's, and while there's been some conflicting data about this, again, this may be an anchor, a way for us to understand this. Now, what's very, very clear is that one of the main causes of adult onset epilepsy is actually trauma. So PTE is a major issue, and it's something that disables our patients long after they've recovered from their TBI, and again, an opportunity to understand epilepsy in a better way. Parkinson's is also strongly associated with traumatic brain injury. In fact, there was a recent paper several months ago that showed a significant risk factor, not only with your first head injury with Parkinson's, but also your second injury, continuing to double the probability that you may develop this. So again, another way, an insight, if you will, into the etiology of Parkinson's. And finally, this very controversial concept of chronic traumatic encephalopathy. This is not a new finding. This was described in the 1900s in dementia pugilistica. So this has been around for a while. I think it's just resurfacing. And what we really need to know is the numerator and the denominator. And so some of the studies that are ongoing, such as the TBI CARE study, may be giving us some insight into what the facts are here. So is it time for a new era in traumatic brain injury? I show you this paper that was written by Weed and McKibben when they came back from World War I. This paper was published in 1919. And the conclusions of this paper were that IV injection of hypertonic solution decreased the size of the brain. So it sounds like that we're still doing that with hypertonic saline and mannitol. And even though it's controversial, even they understood that when the skull's open and the brain's allowed to change the volume freely, that the histopathological changes were not seen. So unfortunately, here 100 years later, I'm standing in front of you and basically describing the way that we treat traumatic brain injury today. So the bar is very low. We have an opportunity to really make a difference. So how are we handling this and how are we approaching this to really usher in a new era for traumatic brain injury? Well, when we look at TBI today, we describe this using a coma score, which certainly is an important universal tool to describe these patients, but we use terms like mild, severe, concussion to describe what is a very complex and heterogeneous disease. Similarly, all these studies that are confusing us because we don't reach a primary endpoint that's acceptable is based on a disability measure, also about 40 years old, called the Glasgow Outcome Scale. And in this, we talk about death and vegetative and good recovery. And if you think about it, the way that we do our preclinical models is with memory and learning tests, the Morris-Watermaze test. And there is absolutely no relationship between this test and disability. So we have not only a translational divide, but a valley of death, and we really need to try to understand how to do a better job. So with traumatic brain injury in 2016, we look at things like cancer, and certainly in my lifetime and as a physician, I've seen cancer, go from this really horrible, scary thing to people now asking, well, what kind of cancer? And we take blood cancers and we divide them and we divide them and we divide them to get a precise diagnosis so we can have a targeted treatment, which is definitely improved outcome. And I think everyone would agree that this has been a phenomenal model for medicine and to show the power of modern medicine and its ability to treat life-threatening diseases. So here we are in 2016 with traumatic brain injury. And so we take the most complicated injury and the most complicated organ in the body, and we divide this into mild, moderate, severe. We just read 2 weeks ago in the New England Journal of Medicine of a trial of severe TBI, where we were looking at randomization of decompressive hemicraniectomy attached to a disability study. Now, can you imagine trying to go to the NIH today or the FDA and doing a cancer trial where we're going to call cancer severe or mild or moderate? I mean, it's humorous because it makes no sense. There's no way that we could do a cancer trial like this. It would be like asking methotrexate to fix every cancer. So I think we just have to embrace the fact that this is a complicated problem, and we're going to have to dig down a little bit deeper to better understand that. Now, what I would say is that we already have a better understanding than we actually try to do on a day-to-day practice. So I put this slide together to try to help some of my basic science investigators understand that severe TBI is not severe TBI. These are all patients with a GCS of 4 that were at my hospital. And I think what you can see here is that all of these scans are radically different. If you look at the scan on the top left there, that's what everybody, even a medical student, would tell you, that's an epidural hematoma. You look at the scan on the bottom right, that's diffuse brain swelling. Now, if you think that you can make a drug that would treat all these patients and fix all these problems, I think that that's just a non-starter. What I would say is that we actually do have a precision medicine diagnosis in one of these scans and a targeted treatment. Look at the top left, epidural hematoma. Who would put an ICP monitor in that patient? Who would give that patient progesterone? Who would do a decompressive hemicraniectomy on that patient? We know what the etiology is. We do a craniotomy, we find the vessel, we bipolar it, we put it back on. These patients actually do pretty well. So what I would say is there are actually phenotypes or endophenotypes within this mess of what we call severe TBI that actually have targeted treatments. And that's really the approach that we're trying to take, is more of a precision medicine approach. So today we use the GCS, mild, moderate, severe. We kind of base this on the symptoms that the patients have. But we actually have many, many more tools to look at these folks that we're using today. So for example, imaging. I don't think that anybody operates on a GCS today. We get a CT scan, we try to find out what the pathology is, and then we make a decision. The role of MRI scan, which no one would think about doing tumor surgery today without an MRI or spine surgery, and yet we still drive every one of the decisions that we make in TBI based upon a CT scan. Clearly room for improvement, and some of the data that we have today suggesting that MRI scan may ultimately replace CT with more rapid MRI sequences. Clinical data. We have an amazing amount of clinical data that we've yet to harvest. The proteome also is becoming very, very interesting. For those of you who've been following the field, and I'll just briefly mention, we have now blood-based biomarkers which are getting very, very close to the ability to diagnose a traumatic brain injury from a drop of blood that not necessarily will change the way we practice in a hospital, but certainly how things are done in the pre-hospital arena. And just like with every other disease, the genome is going to be incredibly important, and we have early data now that's describing some of the genetic abnormalities that we see that seem to be associated with unfavorable outcome in these patients. So how might this work? So if we could build a precision medicine data cube with all of these different layers of information, whereas today everybody's at this symptoms level of mild, moderate, or severe, we may in fact find a ground level truth with something like epidural. So let's just say group A is epidural hematoma. We know what the imaging looks like. There'll be a particularly proteomic signature. But then we may find more complex or more subtle phenotypes. Say, for example, a patient has a constellation of symptoms that maps back to a subtle imaging feature that can only be seen on an MRI scan that also then maps to a proteomic signature. And so this is really what we're looking for, are these group B people, so that we take these severe TBIs, just like with cancer, and we start to divide them out, or the mild TBIs and start to divide them out. And frankly, get rid of the whole mild, moderate, severe and start using things like imaging and so on to describe the phenotype of these individuals. So the way that we're doing this is a study called Track TBI that we've just now crossed over into our 4th year. Track TBI is currently at 13 sites across the United States, many of the places that you'll recognize here. And in January, we're adding on 5 new sites to bring us up to 18 sites. And really the idea of Track TBI is to it's sort of like a Framingham study for the brain injury, if you will. It's a prospective longitudinal precision medicine study where we're following patients over time. It's a team science effort. We have over 75 investigators. I think many of us are convinced that not one individual, not one institution is going to make a difference, not one company. We really have to come together to try to solve this very complicated problem. And this has been the model for many other disease groups like this. We've also built a large public-private partnership, which we call the Collaboratory, and this involves many of our private partners that have a stake in this game, the imaging companies, diagnostic companies like Abbott, some of the smaller biomarker companies. I've been working very closely with philanthropic organizations that have helped us to fill in the gaps of the budgetary needs that are required for a study like this, and many academic partners. So it's a prospective longitudinal observational study of about 3,000 subjects, including controls, and it's across, so we're going back and using the old terminology, concussion to coma. It's across the whole spectrum of TBI. The goals are to really improve the diagnosis and classification. We need better ways to describe these people if we want targeted treatments. But we're also trying to look at the outcome assessments, which are equally as crude. The outcome is as crude as the way that we stratify these patients on enrollment. We're trying to look at the health and economic impact of mild TBI. And if I could ask you to take one other thing away from this morning, mild TBI is not mild. If you follow these patients carefully and you do a structured outcome assessment on these folks at 6 months, particularly those that you see as a neurosurgeon with positive findings on a head CT, there's nothing mild about that. There's a lot more disease out there than I think we've appreciated. And it's only through this structured follow-up that we're beginning to discover this. And ultimately to create this data cube that will allow not only our team, but anybody that's in this room to approach us and to start working on this. This is truly big data, big team science kind of effort. And I would invite any resident, anybody that's in this room that's interested in working on this data set. We have a collaboration agreement. We're open arms to working with anybody that's here that wants to try to help us solve this problem. So as of yesterday, we were at 1,707 subjects. This is the largest prospective longitudinal study at this level of detail with the imaging, with the genetics, with the proteomics that's been done to date. We have a tremendous amount of imaging that's part of this study. So I don't have time to give you great details, but would be happy to talk to you later. Clearly, we're finding that 3T MRI is better than CT scan. There's no surprise there, and we're working with the FDA now to try to help to establish a biomarker for enrichment for clinical trials with this. We have volumetric imaging, we have tractography, very exciting data coming out looking at the resting state, function of the brain to try to better understand. It's not just about doing a decompressive hemicraniectomy. If you're going to stop the brain from swelling, the underlying brain has to be intact and has to be functional. And some of these biomarkers, I believe, are going to help us with this. As I said earlier, we have a blood-based biomarker that we've been looking at, GFAP and also UCHL1, which already have receiver-operator curve characteristics of some of the tests that we're using today, like BNP, in our clinics. So I think we're getting very, very close to having a blood-based biomarker for traumatic brain injury. We also, as I said, are having some great luck looking at some of these more hypothesis-driven polymorphisms and things like the dopamine serotonin pathway, some of the degenerative disease pathways, and again will help us to understand why some people recover and some people don't. I show this slide to you not to really dissect this, but to say that we've been using a global outcome measure, and many things go into a global outcome. It's your cognitive, it's your psychological health, it's really your physical function. And so within this study, we have 26 outcome measures, and we're trying to look at all the facets of traumatic brain injury. Not that we would use these in the future, but to try to find those one or two measures that will be more sensitive than the disability measure that we use today. So what I hope I've shown you is really a new way forward in traumatic brain injury, this idea of building a knowledge network, of going beyond mild, moderate, or severe to really try to better understand what is the phenotype of these patients, how do we look at them in the acute stage, how do we follow them long term, and really better understand this complicated problem that we deal with. This is also part of a much larger international effort called INTBEER. We're having a meeting in a few weeks in DC, but we have Canadian partners that are using similar biomarker protocols, imaging protocols. We have a sister study in Europe called Center TBI that some of the folks in the room may be part of. Again, we're using actually the same database such that the 3,000 patients that we will have can be merged up with the 5,000 patients in Europe. We can look at comparative effectiveness research questions. This is going to be a very powerful approach. Our colleague Jamie Cooper in Australia has a study going doing the same thing and we also have some very nascent efforts that are spinning up in China and India. So again, this is an international effort. This is not new. Anytime that you have a complicated problem, if we look at particle physics, one investigator, one university did not build that machine on the top left. This was really the work of 608 institutions and 113 nationalities. And I just basically give you this as an idea. The way that we're going to solve these big problems in the future, in my opinion, is with team science, is with big data, as we try to move forward in making a difference that we really haven't made in the last 100 years in this field. So I'll leave you with the idea that I think that we are paving a new way for traumatic brain injury. I think we're accepting that it is complicated, but we have lots of tools to solve this now. I mean, you know, the computer capabilities that we have, all the imaging techniques that we have, GROS, all these things makes it a very, very exciting time to be doing this. But again, if I can leave you with one final thought, neurosurgery must play a role. This is not something for us to abdicate. We need to be in here taking care of these patients. We need to be overseeing the care of these folks. No one takes care of these patients in the emergency department after they're left. We found that less than half of these people in our sites are being followed up. So there's a real opportunity here for neurosurgery, I think, to take a leadership role and to help these folks. This is a growing problem. This isn't going away. And the field of neurotrauma needs all of your help to make the advances that we need for our patients. Thank you very much.